talk about all the justice-involved programs that fall under the Office of Mental Health. And these are the ones that we have. As she said earlier, most of my career has been with emergency services, working out of the Charleston-Dorchester Mental Health Center. About 3 years ago, I moved into a position where I was just involved with the first responder support team. Still worked out of Charleston, but supported the whole state of South Carolina. So worked technically out of our central office in Columbia. A year ago, I was given all programs that touch law enforcement except for the mobile crisis team. So I oversee the Mental Health Law Enforcement Alliance program, our detention embedded program, mental health court, still the first responder support team, and I'm the liaison with the South Carolina National Guard, the South Carolina Department of Corrections, and South Carolina Probation, Pardon, and Parole. So for those of you that aren't familiar with the department or the office, we're now the Office of Mental Health, we have 16 mental health centers across the state. But although we only have 16 mental health centers, they provide services in every county in the state. So we provide services to all 46 counties in South Carolina. The programs that we are getting ready to talk about, we do not have all of these programs in all of these mental health centers. So as we discuss them, we'll talk about where they're located. Our hope is absolutely to get them in all mental health centers across the state. These programs were really developed, the mission for the Office of Mental Health is to support individuals in their recovery from mental illness. And these programs allow us to go where these individuals are and continue to support them in their recovery. So folks that are in the detention center, we have a lot of folks in the detention centers who are struggling with mental illness. They can't get into our mental health centers for care. So this allows us to go to them and help keep them in their recovery. So the first one I want to talk about is our Mental Health Law Enforcement Alliance program. This is a team of clinicians who are embedded in the local police departments in their area. So the main intent of this program is really to kind of enhance the collaboration between law enforcement and mental health. Having a clinician who is on site provides constant consultation for these officers. So these officers might go out into the community and get in front of the same person 3 or 4 times in the same week. They can step into this clinician's office and say, hey, this is the 3rd time I'm going out to see this person. This is what family's saying. This is what neighbor's saying. This is what he's saying. Can you kind of help me figure out what's going on? So this clinician can either connect him, provide him with resources to get to this person. This clinician may say, well, why don't I just ride out there with you? Talk to him, see if we can figure out what's going on. So another way these clinicians help is providing trainings for these officers. So they do a lot of presentations just around mental health awareness, different topics associated with mental health. When the police departments participate in community events, these clinicians go with them. So the community see mental health and law enforcement standing shoulder to shoulder and serving the community. Another way these clinicians help the officers is as the rapport and the relationship strengthen between the clinician and the officers, we often see the officers step into their offices, shut the door, and say, hey, can I talk to you quickly about this thing that I have going on in my life, in my personal life? Sometimes it's, they've been involved in a critical incident and they are just kind of feeling the stress reactions that are very normal, and sometimes that clinician can just normalize that for them, give them some tips on how they can manage those reactions in the next few weeks. If it's something a little bigger than that, these clinicians can say, it sounds like you might benefit from some mental health services. Let me give you some referral sources. Maybe it's our first responder support team. Maybe it's a private provider in the area. But that officer's ability to trust our clinician enables that officer to trust that referral and be linked to that person for ongoing care. These clinicians would not provide that ongoing care for the officers because that would be a dual relationship, which is unethical in the clinical world. These clinicians also serve in a role kind of similar to the mobile crisis team. So every mental health center in South Carolina has a mobile crisis team. Officers might be on scene and request mobile crisis to come out to them. Mobile crisis might be on another scene, and it might be an hour, hour and a half before they can get out. These officers can call their embedded clinician and say, do you have ability to come out? And they would provide the same evaluation that that mobile crisis clinician would provide. And like I said earlier, they may just ride out there with the officer if they know that they're going out to a crisis. So they kind of serve in that same role. They can do that same psychiatric evaluation, and then the goal is to get them linked to outpatient care and divert them away from a hospital. If they do need to go into a hospital, these clinicians can help with that process. These clinicians are also trained to support individuals in the community who have been through traumatic events. So they receive additional training in trauma. So a lot of them are trained in EMDR. A lot of them are trained in trauma-focused cognitive behavioral therapy. And if someone is a victim of domestic violence, if they've been sexually assaulted, if there's been a major violent episode in the community, these clinicians have the skills to go out on that scene and provide immediate support and then walk with that person through that recovery. One thing we know in the mental health world is the sooner someone connects with support and services, the better off their recovery will be. And these clinicians working with the officers can get out there right after the act has happened. So these are the locations across the state that we currently have these teams embedded. You will see that some areas have more than one clinician. Charleston, Dorchester currently has 7 clinicians in those 2 counties. This is some of the data that we track with this program, those consultations that I talked about that these clinicians provide for the officers. Now, this data is for the last 9 months. We usually like to present data for a fiscal year. I newly acquired these programs in May of last year. It took me a few months working with Debbie to kind of get our data collection tool created and sent out to the centers. So this is 9 months of data. So in the last 9 months, they've provided 4,246 consultations, which is an average of 472 consults a month that they are able to support their officers. They average about 78 community responses a month. 19 trainings are being provided a month with these teams. They are attending an average of 37 community events with their police departments, and on an average they're serving 513 individuals a month. Now with this team we also track diversions, hospital diversions, ED diversions, jail diversions. Like I said earlier, our intent is to create safety plans with folks who are in crisis to keep them out of those inpatient settings, link them to appropriate outpatient care, and our ability to do that saves the community dollars. So we do track how many diversions that we're able to assist with. Hospital diversions, the average cost for a client with or a patient with Medicaid for an inpatient stay is $5,600 for a 7-night stay at the hospital. So we average 63 a month that we are able to divert. So that's a big chunk of money that this program helps save the communities. And they average 74 jail diversions each month. This graph kind of indicates the reasons that referrals are coming in. You'll see that psychosis and trauma are kind of the two biggies that kind of get our folks in front of them. Depression and suicidal thoughts, anxiety, those come next, and then mania, grief, and homicidal ideations.
When was the HI and SI?
I'm sorry, HI is homicidal ideations, and SI is suicidal ideations. All right, so our detention embedded services. These clinicians, just like with the Alliance program, their offices are inside the detention centers. They provide assessments to the detainees. They provide group therapy to the detainees and other therapeutic services as needed. They do a lot of collaboration with psychiatrists for medication management. Now, some of these detention centers use the Office of Mental Health psychiatrist for medication management. Some use the medical providers that they have in their detention centers that they have contracts with. These clinicians can communicate with both those medical providers to help these detainees stay on their medications or start medications if needed. They also collaborate with, if someone goes into the detention center and they're an active patient with the Department of, or the Office of Mental Health, these clinicians can communicate with those therapists at the center to let them know that their patient is in the detention center and get their medical records, and again help these folks stay on their medication. And they can do the same thing with private providers. If they know someone is in the detention center and they see a private provider, they can help with that collaboration also. And just similar to going into the detention center, when these folks come out of the detention center, these clinicians can be that bridge that link them to ongoing outpatient treatment for that continuity of care. These clinicians also, since they are on site, they provide education to the detention officers that work in the detention center. They can provide trainings, they can do consults, a lot of the same benefits that we see with the Alliance teams. This is currently across the state who we have contracts with in the detention centers. How many of you folks are here in the Florence area? All right, so we have 2 detention centers here in this area that we have a clinician in. Stephen Williams serves in those detention centers. And if you can see on there, I know it's kind of hard sometimes to read the print. This graph kind of indicates who we have contracts with the psychiatrist from our Office of Mental Health and who they're contracted with just through their medical provider in the detention center. All right, so this is some of the data we track with these teams. So you'll see per month we average over 1,000 contacts between the detainees and the mental health clinicians. Each month we're averaging 150 contacts with our psychiatrists, 116 contacts with the jail psychiatrist. We try to help these patients stay on their injections. For you guys that aren't as familiar with the clinical world, there are a lot of the medications that we use in their recovery are now in the injection form. And we've really seen a lot of benefit in helping our patients stay stable. They help do the assessments to go on suicide watch and to come off of suicide watch. And you'll see that on an average each month, this team provides over 1,700 services to the detainees. All right, so again, these are some of the diagnoses we see within the detention centers. You'll see that the two largest categories are substance use disorders and depression. And as we all know, a lot of times the substance use disorders are co-occurring with other mental illnesses. Anxiety is another big one, schizophrenia, PTSD, and bipolar disorder. All right, mental health court. So this program was designed to divert qualifying mentally ill patients away from the criminal justice system and into an appropriate treatment program. These individuals do have to be willing to plead guilty to the charge. So if someone enters this program, their charges are not dropped or expunged, they plead guilty to the charge. It's an intensive program. It involves individual therapy, group therapy. They might be required to do their substance use treatment. The team, the mental health court team, communicates weekly with probate court, with mental health, with public defender's office, solicitor's office, law enforcement, voc rehab. You can see all the community partners on there that this team works together. Most of these folks are in this program for about 12 months, and the intent is to have them graduate, stay connected to treatment, and be enhanced in their recovery. The offenders do have to voluntarily enter the program. They have to have a nonviolent charge. We have a few in these programs that do have felony charges, but they have to be nonviolent felony charges. And they have to be willing to plead guilty. And if they are found non-compliant, if they start missing appointments, if they pop positive on a drug screen, they could be kicked out of the program, or they could be sanctioned to where maybe they have to do more therapy sessions during the week, or they go to jail for the weekend and are detained for a certain number of days. Not kicked out of the program, but they do get consequences for not following the requirements. And these are the mental health centers who are currently supporting this program across the state. Spartanburg is our newest, so we're excited to see them. And this is some of the data that we track with them. On an average, they serve 85 participants a month, provide 12 assessments a month. We have an average of 4 successful completions or graduations, average 9 court sanctions, and then on each month we average about 18 of them also in co-occurring treatment. They have to live in that county. It's not the county that the charge occurs, it's the county where they live. And the reason I identified, so like Anderson, Oconee, Pickens, they serve 3 counties. But Anderson County is the only county in that catchment area that has a mental health court program. And like Columbia, they cover Richland, Calhoun, not Calhoun, Fairfield, and what was the third one?
Columbia just said.
Okay, so if someone lives in outside Richland, they would not qualify for the program. All right, first responder support team. My first responders in here. How many of you guys have heard of that program? All right. So this is a team of clinicians who provide mental health services to first responders and to their family members. They receive training in kind of the culture of the first responder world. They work very closely with the peer programs in the state, so SC LEAP, the South Carolina Law Enforcement Assistance Program, SC FAST, which is the Firefighter Assistance and Support Team. Down in the Low Country Firefighter Support Team. These clinicians work very closely with those peers. They too have additional training in trauma, so they're all trained in EMDR, which is a type of trauma treatment that we have found to be highly effective with first responders. We're all invited to those post-critical incident seminars to provide EMDR to first responders. Post-critical incident seminar is a 3-day trauma-focused program for first responders. It's facilitated through SC LEAP, ran by peers, but they have vetted clinicians who are invited for the purpose of meeting with participants there and doing EMDR if appropriate. It involves chaplains. We've got they have medical massage therapists there. It's really a phenomenal program. One of my favorite things I do in my position. They help with critical incident stress debriefings across the state, which again is led by peers, and our clinicians will join and do a 10-minute little education piece on normal stress reactions and coping strategies that can help, and when to recognize that these normal reactions have advanced into a more serious need. They do a lot of trainings for first responder agencies across the state around mental health awareness and different topics related to mental health. And then some of them are trained in crisis negotiations and can assist law enforcement negotiators when they're out on critical incidents with resolving the crises. These are the areas that we currently have our clinicians located. We have 2 here in the Florence area. Tamara Williams and Taylor Peterson are our first clinicians that work in this area. Now, this program, one thing that kind of differs with this program than other programs within the Office of Mental Health is we don't restrict the clients to their county of residence. So we currently don't have a first clinician in the Myrtle Beach area, but we've got several first responders from Myrtle Beach that will travel to Charleston and that will travel here to Florence to see these clinicians, because these clinicians kind of understand what these first responders get in front of. They get the culture, they get the humor, they get the significance of what they do, the schedules. So we do not restrict that. We also have some first responders who don't really want to receive treatment in their area. They would prefer to drive an additional 45 minutes. So wherever they feel more comfortable, we link them up to that treatment. They provide telehealth and in-person, so they have virtual option and in-person option. To get connected to treatment, we have a statewide referral phone. That the number is up there. I'm the person that answers that phone, so when I get the call, I spend a little bit of time with them, kind of figuring out what's going on, where they live, and again, kind of determine what's going to be the best location for them. And then I email their information to the clinician in that area. That clinician calls them to schedule the initial appointment. And again, they treat the first responders, but they also treat spouses, significant others, and children. of the first responders. Now, in the Charleston, Berkeley, Dorchester areas, so this program originated in Charleston after the Sofa Superstore fire back in 2007. We lost 9 firefighters in that fire, and it was a partnership with the City of Charleston, with the Office of Mental Health, the Charleston Dorchester Mental Health Center, and the National Fallen Firefighters Association. And they created a team with the peers and the clinicians that supported those firefighters. For 6 years, they provided mental health services to the firefighters and their families. After 6 years, we opened the doors to all first responders. So we work with law enforcement, EMS, fire, still, coroners, correction officers, detention officers, all branches of first responders. We also see soldiers, we see military. One hurdle we run into sometimes is the funding, the TRICARE. We're currently not in network with TRICARE. I think we are trying to get in network with TRICARE. But we also have an MOA with the National Guard. They have some of their folks who have not signed up for the military insurance, and we can link those folks into our program for care. So this is some of the data we track with the first responder support team. This is for a whole fiscal year, July 1st of 23 to June 30th, 24. We had 313 new referrals to come in, served over 2,800 patients, and provided over 4,000 services. The debriefings, we participated in 118 critical incident stress debriefings, and we served 1,650 first responders in that role. We participated in 6 post-critical incident seminars, which allowed us to support 187 first responders. And then we participate in the crisis intervention trainings that a lot of the I know law enforcement do. I've seen a few EMS agencies starting up with it. It's a 40-hour training for first responders focused on crisis intervention, and we'll come in and do a presentation on mental health awareness, specifically focused on first responders. So again, these are the justice-involved programs that currently fall within the Office of Mental Health. In my role, I am also the liaison with the National Guard, with the Department of Corrections, and with probation, pardon, and parole. So what that looks like is if someone is being released from prison, say they are in prison down in Ridgeville, South Carolina, but when they're released, they're going to go up to Spartanburg or return to Spartanburg. Maybe that's where they're from. The social worker within the prison can reach out to me, and I can link them to the center director at the Spartanburg Mental Health Center. I can help them connect and make sure all the appropriate medical records are transferred, and then we agree to see the inmates within 2 to 3 business days of release. Again, we don't want them to fall out of treatment. We're wanting that continuity of care. Same thing with probation and parole. If someone's coming out of prison and they're going to be on parole, that officer can reach out to me. I can help link them to whatever catchment area they're going to be in.
So we're trying to keep people from, keep public defenders specifically, from wanting people to go through a restoration process. So it's a restoration for competency to stand trial. Complicated, I'm not going to get into all the legal stuff, but when lawyers try to get person into a restoration situation, they're just prolonging the person's time in jail. So we don't want people to stay in jail. We want people to get out of jail quickly if it's safe to do that for a public safety standpoint. So we're creating a program called DDT. Some of my staff hate it. I like it. I think it's funny. It's deflection and diversion team. And it's where we're not embedded in a detention center. And you see we're only embedded in 13 detention centers across the state. So where we're not embedded, it's for every mental health center to have a staff person that can go into any detention center in that catchment area. We have some mental health centers that have 7 detention centers in their catchment area, and some that only have 1. Go into any detention center, identify a person who has significant mental health issues. I'm not talking about I'm depressed and I'm anxious because I'm being detained. I'm talking about I have a history of a mental illness, and that's causing me more problems. Because we know that people with mental illnesses, particularly serious and persistent mental illnesses that sit in detention centers, do nothing more than accrue more charges, right? It's a terrible environment for somebody with schizophrenia. I become more paranoid, I become more anxious, I become more psychotic, I throw my poop at you, I throw my pee at you, I throw my food at you, and I accrue more charges. So it's just a bad situation. So if we can identify people really quickly, before, best case scenario, before they ever go into detention, like with mobile crisis and alliance programs, but obviously we're gonna miss some. So when they get in, but before they accrue more charges, these clinicians will be able to go in, identify these folks. We can look in our records, see what we have, and because we have a uniform system that covers all 46 counties, and we have information that any clinician can look at from any catchment area and see what's happened with a person, we can try to get them into other programs in the outpatient setting, not in a detention center. Obviously, if they need hospitalization, that's a different story. But if we can get them out of detention, again, safely, in cooperation with the solicitor, with the law enforcement, and with their public defender, that is what these clinicians will be doing. So they'll be identifying folks whether or not we have a contract with the detention center. The detention center will have to agree through an MOU to allow us into the detention center, because they don't have to let us in. So we are getting ready to launch this MOU to all 46 counties to see if we can come in the detention center. I presented at the Jail Administrators Association, and I didn't have any jail administrator that said, no, you can't come in. They would like these folks that don't need to be in detention out of detention, because it just makes their lives harder, right? And it's terrible, again, for the detainee who doesn't need to be there. So again, all 16 centers will have this. And I like to stress that one of the beauties of having the Office of Mental Health be a state-owned entity is that if the state wants it to do something across all 46 counties with funding, we can do that. And so this is one of the things that we're putting a high level focus on. Yeah. So like for the programs that DeLynn was referencing, like Alliance, that's up to the law enforcement agency, whether it's a sheriff's department or a police department, to say, yep, we want in, or we don't want in. There is a cost share to that unless we find a grant, or the law enforcement agency finds a grant for that. For the detention centers, same thing. The detention center has to want to have a contract with us. There are some detention centers that have medical contracts with private medical providers, and then they'll have a separate contract with OMH. To provide the psychiatric side of it. Some detention centers will only have a contract with OMH. Some, again, will be a sub-recipient of a contract through a private medical provider. So we can do it all kinds of different ways. 13 contracts look 13 different ways for those detention centers. And with the Alliance program, they're all a little bit different too. And we have a lot of law enforcement agencies reaching out to us, asking for more clinicians. And every year when we put together our budget, we're typically asking for dollars from the state to support the Alliance positions. Because those programs have a profound effect, as you saw from some of the data, of keeping people out of the criminal justice system. So I'm going to put a plug into something that we're going to be hosting September 25th and 26th. It's a statewide system intercept mapping for the state of South Carolina. And it's going to be a high-level SIM, if you're familiar with SIM. SIM comes out of the Gaines Center, and again, it's system intercept mapping, and it looks at mental health and criminal justice, or substance use disorders and criminal justice, and where they intersect one another, and what a community can do, because they're usually done county by county, what a community can do to keep people out of the criminal justice system who live with a substance use disorder or mental illness. But this one is gonna be a statewide summit and look at some of the big issues that we're facing, and restoration is a really big issue. If you're not aware, the Department of Mental Health is the Office of Mental Health. You know, we've been saying that for 200 years, so you gotta get used to Office of Mental Health. The Office of Mental Health is responsible for restoration, for competency to stand trial. And we have a forensic hospital, and those evaluations of restorations occur there. However, in 2023, the General Assembly passed a law that allows us to provide restoration services outside of a hospital setting, which is great. So they can happen in detention centers, they can happen at a person's home, they can happen in a mental health center, they can happen all over the place now, which is really, really good. Because if you only have 217 forensic beds, but you have 153 people on a waiting list, those folks are waiting typically in detention centers. Again, not good for anybody. So, yes.
Two questions. What date did you say SIM was?
The SIM is going to be September 25th and 26th, and we can only have 75 people. And obviously, we're inviting a lot of, people over like corrections and other places. But if you have a definite interest in it, give Dylan your name, and if we have spots that open up, we can open it up to other folks for sure.
And thank you. And the second question, the individuals that are being detained, do they have to come with a diagnosis? Do they have to already be diagnosed with a mental illness when they're detained? That's.
When we're embedded in a detention center, for us to serve
For
those
the
folks.
ED?
Oh, so, no, let's say that a person is just exhibiting behaviors that the detention center notices and says, yeah, maybe we should see this person. So they don't have to have a diagnosis, no.
That's right.
Yeah.
And when do you see that happen? A year, 2 years?
We have the funding. Because we are in the process, and I'm going to talk about this at my lunch session, of merging the Department of Mental Health with the Department of Disabilities and Special Needs with the Department of Alcohol, I always say it wrong, Department of Alcohol, Drugs, and Other Substances of Abuse, DAODAS. Now we are all the office of, under the South Carolina Department of Behavioral Health and Developmental Disabilities. So I say that to say, because we are merging into this greater entity, the hiring process is just being slowed down just a teeny little bit because we have another layer of bureaucracy over us. So the positions are posted, and we'll see how quickly we get them hired. Hopefully quickly. Yep. Yep.
All right, thank you. All right, any questions about any of the other programs that we've talked about? All right. Well, thank you guys for joining me.